We're going to get started and talk about CNS infections for the next 30 minutes. We're going to get started first with our unknown cases. This first case is a 19-year-old female with headache and periorbital edema. Okay, so this next case is a 23-year-old migrant worker who comes in with a headache and left upper extremity weakness. Okay, this next patient comes in with a new seizure. So this is an 11-year-old female. She's neutropenic after a bone marrow transplant who comes in with a new fever. And our last unknown case is a 31-year-old female with HIV who comes in with right hand weakness. Okay, so this morning we're going to talk about CNS infections and we're going to work our way from the outside in. And first I want to briefly review the anatomy of the meninges. You can see that the dura mater is divided into an outer periosteal layer and an inner meningeal layer here that forms the dural reflections such as the falx cerebri. So you can see why epidural abscesses like epidural hematomas that are tacked down at the sutures, they can cross midline, but subdural empyema cannot cross midline and will turn inward along the dural reflections. We're going to also talk about the arachnoid mater and the pia mater together, which make up the leptomeninges. And then we'll talk about parenchymal abnormalities, including pyogenic abscess and encephalitis, and talk about specific pathogens along the way and opportunistic infections in the setting of HIV. Today I want to give you a practical or board's approach to approaching these type of cases. So we're going to look at one of 5 basic patterns. The first is an extraaxial pattern. The second is a pattern of ring-enhancing lesions. The third, temporal lobe lesions, basal ganglia lesions, and white matter lesions. And instead of giving a laundry list of differential considerations, we're going to use specific imaging characteristics that we discussed today. And of course, diffusion is going to be a key sequence when we're dealing with infection, and use clinical history to tailor the differential diagnosis, and in many cases come up with a specific diagnosis. So the first pattern we're going to discuss is the extraaxial pattern. So here's our 19-year-old that comes in with headache and blurry vision. And you can see on the bone window that the patient has opacification of the sphenoid sinuses. So a sphenoid sinusitis, but she also has blurry vision. So that's your clue that you need to look outside the sinuses. You need to look at your cavernous sinuses. And when you look at the cavernous sinuses, you see that they're bowed, expanded with filling defects. And this is cavernous sinus thrombosis. And if you look carefully on that same image, you can see thrombus extending into the superior ophthalmic vein. And when you look at the coronal post-GAD, you can see that this patient has an epidural collection extending into the middle cranial fossa here, and that's an epidural empyema or abscess extending from the sphenoid sinuses. So epidural empyema or abscess is usually going to extend from the paranasal sinuses, with the frontal sinuses being the most common. Remember that you may not always see bony erosion because you can have spread through the valvulus bridging veins. And remember to look out for associated complication. And here's an example of a frontal sinusitis with an adjacent epidural abscess in this 11-year-old boy who presents with a headache. So our next case is a 56-year-old who came in with fever and left leg shaking. A very subtle post-contrast CT, but if you look carefully, you can see leptomeningeal enhancement. This patient had meningitis, already had CSF showing meningitis, so this is really not the critical finding. But what you should notice here is this patient also has a periphalcine subdural collection. And the differential now, is this a subdural effusion or is this subdural empyema? So the sequence that you want to get next on MRI is diffusion. And you can see there's reduced diffusion in this patient with meningitis and a subdural empyema. So subdural empyemas are important to recognize because of the high mortality associated with them, and often they need to be surgically evacuated. They can be associated with brain abscess and dural sinus thrombosis, as you can see in this case with a brain abscess that's ruptured into the subdural space. In young kids, it's often the sequela of meningitis, as we just saw in this case. However, in adults, they often extend from the paranasal sinuses like the epidural empyema. They're going to be bright on diffusion, and the location is commonly over the convexity, but can also be periphalcine. So the main differential considerations are the subdural effusion that we discussed, Chronic subdurals can be a mimicker because they can enhance and they can have funny diffusion characteristics because of the blood products. So look at the T1 sequence, look for evidence for susceptibility, and know the history. Next case is another subtle CT. This is a 45-year-old male with a headache. But if you look closely at the subarachnoid spaces at the vertex, you see that the subarachnoid spaces are asymmetric. On the right, you can see that they are filled in with an isodense material. And of course, the coronal flare makes the finding more obvious. You can see over the right frontal vertex, you've got bright signal in the subarachnoid space. So we're going to pause here for a differential for bright signal and flare in the subarachnoid space. The big ones are tumor, pus, and blood. You can also see high signal with slow flow. So if you have ipsilateral carotid stenosis and PO collaterals, you can also see this appearance. So be thinking about that, especially if you were to see watershed infarcts. And also oxygen therapy, which tends to be more diffuse. So here's the same patient. You can see the post-contrast, the leptomeningeal enhancement following the sulci and gyri, and the reduced diffusion in this patient with meningitis. So when you have a patient with meningitis, look out for the complications, because this is where you can really help the clinicians. Look out for infarct, hydrocephalus, subdural empyema, and look at your dural sinuses. So here's our second unknown case. This is a 23-year-old migrant worker with headache and left upper extremity weakness. And if you look closely on this non-contrast study, you can see that the basilar cisterns are filled in with isodense material. So it's slightly hyperdense, isodense. 9 times out of 10, when you see hyperdense material in the basilar cisterns, you're going to be dealing with subarachnoid hemorrhage. But I want you to remember that you can also see this appearance with pus. And here, when you see the post-contrast, you can see there's diffuse enhancement of the basilar meninges. So what is a differential for basilar meningeal enhancement? Well, TB and fungal infection are the big 2 infectious causes, and you can also have this in sarcoidosis. And here's the patient's non-contrast CT at the level of basal ganglia. We see this infarct in the posterior limb. So this explains the patient's left upper extremity weakness. And these infarcts of perforating vessels are fairly common in the setting of basilar meningitis because of the inflammation and obliterative vasculopathy. And this is a patient with coccidiomycosis. So in summary, for meningitis, CT is pretty insensitive, sometimes done before lumbar punctures. On MRI, you want to use your flare and GAD sequences for the subarachnoid abnormality, but use your diffusion to look for complications. Acute bacterial and viral meningitis normally presents with enhancement over the cerebrum, and chronic fungal or TB meningitis has basilar cistern enhancement. And this is just to contrast leptomeningeal enhancement with pachymeningeal enhancement. And you can see this follows the dura. So it follows the inner layer it follows the periosteum and the dural reflections. And this has a different set of differential considerations than leptomeningeal enhancement that we've seen that follows the sulci and basilar cisterns. So the second pattern, we're going to look at ring-enhancing lesions. So you can see this patient has ring-enhancing lesions in both frontal lobes. And we're going to pause here for a more broad differential for ring-enhancing lesions that Dr. Cha discussed briefly earlier. So metastases, these are usually multiple and usually at the gray-white junction. For pyogenic abscess, as we'll see, the key features are light bulb bright diffusion and a more thin rim of enhancement rather than thick rim that you see with tumor. GBM, we've seen, usually have solid and necrotic components. They like the corpus callosum and the deep white matter, but of course they have a multitude of different imaging appearances. Hematoma, remember subacute hematoma can have ring enhancement. Radiation necrosis, usually the enhancement here is more feathery, not as much ring enhancement, but it can be a mimicker, and perfusion can help. Tumefactive demyelination, this is a big one to remember. So incomplete rim of enhancement, one of the major clues is for the size of the lesion, there's very little mass effect. An infarct, which is usually more gyriform, but remember in the cerebellum and in the basal ganglia, you can have more tumefactive enhancement. Atypical infections we'll discuss, and toxo versus lymphoma, and here again is where knowing the immune status is key. So here's the same patient. You can see multiple ring-enhancing lesions reduced on diffusion. And this is a patient with multiple pyogenic abscesses from septic emboli. So here's a 65-year-old female that comes in with fever and vision loss, and you can see a lesion in her left occipital lobe explaining her vision loss, and this just illustrates the classic imaging features for pyogenic abscess. You can see on T1, it's hypointense. On the post-contrast images, we see a small daughter lesion. You also see thin, smooth ring enhancement. And then on the T2 sequence, you see that the center is hyperintense and the ring is hypointense. And of course, the key sequence here is the diffusion, light bulb bright diffusion on your diffusion images, and the ADC map shows that it's truly reduced on diffusion. This is a pyogenic abscess, usually hematogenously spread. Look out for the complications that we've discussed earlier, including ventriculitis, because these can rupture into the ventricle. So what are the imaging features that are going to favor pyogenic abscess over neoplasm? Well, as the body tries to wall off the abscess with collagen deposition, it's usually asymmetric. So you may have a thinner rim of enhancement towards the ventricle with abscess, and this explains the propensity for intraventricular rupture. Daughter cyst, the light bulb bright diffusion. Remember that some tumors that are hypercellular, including lymphoma and some high-grade glial tumors, can also be bright on diffusion, but they won't have this thin, smooth rim of enhancement in most cases. And then remember the T2 hyperintense center, which is going to be different than some of the atypical infections that we're going to discuss. So here's a 65-year-old that came in with a fever after shunt placement. And again, you can see a small abscess. This is very close to the ventricle. And if you look close at that ventricle, you can see the signal intensity of the ventricle is different. And there's subependymal enhancement along that ventricle. And then you look at the T2, you can see this abscess is ruptured in the ventricle with debris, which is reduced on diffusion in this patient with ventriculitis. So these are rarely isolated. They're usually associated with meningitis or shunting or a ruptured abscess. But they have really high mortality, up to 80%. So the next case is a 3-year-old with a fever and an abnormal chest x-ray. So again, on a post-contrast CT, we see fairly thin, smooth ring of enhancement and vasogenic edema in the left cerebellum. It's hyperdense on non-contrast, so that's a little bit atypical for a pyogenic infection. And then when you look at this patient's MRI, you can see it's hypointense to slightly hyperintense on T1, a rim of enhancement on the post-contrast. But here's the real clue. If you look on the T2 weighted sequence, it's homogeneously dark on the T2 weighted sequence. So putting this together with an abnormal chest x-ray, one of the things you should suggest is a caseating tuberculoma, and that's what this is. And if you look at this patient a year later, you can see the calcification after treatment. So here's a 43-year-old with acute altered mental status. So on the post-contrast image, you see multiple ring-enhancing lesions. You also see some that have more punctate and linear enhancement. So ring-enhancing lesions, of course, you're thinking metastases, you're thinking septic emboli. But then you look at the FLAIR image and you think, this does not look like metastasis and septic emboli. And why is that? Well, if you look at the FLAIR, the size of the lesion really almost matches the ring-enhancing lesion, so not very much vasogenic edema and little to no mass effect. And then if you look at the diffusion images, you can see these are not reduced on diffusion, further evidence against pyogenic abscess. And this is demyelination. This is tumefactive demyelination, a pretty classical appearance that you should be thinking about when you see these ring-enhancing lesions without much mass effect. And this is a patient with ADEM. This is a week later. So you can have multifocal abnormality in the basal ganglia and white matter, often 10 to 14 days after infection or vaccination. The key here again is minimal mass effect. The enhancement can be variable. These are more common in children and adults and is a monophasic illness. So here's our third unknown case, a patient with a new seizure. So another ring-enhancing lesion. When you look on the T2, it has the dark T2 rim, centrally hyperintense, like the pyogenic abscess. However, when you look at your ADC map, it's bright on the ADC map, so it has increased rather than reduced diffusion. So this would not be compatible with a pyogenic abscess, and now we have to start thinking of atypical infections. And when you look more closely at the T2 weighted sequence, you can see the central dot of T2 hypointensity, and that's the Scolex. And this is a patient with Neurocysticercosis. And I also showed you the gradient sequence, which is another clue, because you can see the area of susceptibility that corresponds to the area of calcification on the CT scan. So the 4 stages of Neurocysticercosis that you should know about. The vesicular stage is really the cyst in the dot. You won't see edema. The cyst density will follow CSF on CT, and the intensity will follow CSF on MRI. The colloidal stage is where you see the enhancement and the edema. This is because the Scolex is degenerating and causing inflammation. And as you progress through the granular nodular stage to the nodular calcified stage, the lesion mineralizes and there's no edema. So here's the myriad of different appearances that you may see with Neurocysticercosis. Remember, even the vesicular stage, the patient can present with seizures and even hydrocephalus. So you can see here multiple cysts with a central dot, and this is a vesicular stage, no edema. Here's the colloidal stage. You can see the ring enhancement and the surrounding T1 hypointensity compatible with edema. And here you have both the vesicular and the nodular calcified stage. So our next unknown is 11-year-old, the neutropenic patient with a fever. So on the T2, you see a very large area of T2 abnormality. Some punctate areas are darker on T2. On the post-contrast, you see some areas of thin enhancement, posteriorly a little bit more irregular. But notice for the size of the lesion, the size of the enhancing lesion, again, very little vasogenic edema, very little mass effect. Of course, you can see some mass effect here on your coronal gradient sequence on the frontal horn, and you can see some blooming and susceptibility from hemorrhage in this case. When you look here at the diffusion sequence, you can see centrally it's not reduced in diffusion like a pyogenic abscess. And when you have a patient that's neutropenic and you see hemorrhage and very little mass effect, you should be thinking about fungal infections such as aspergillosis. And that's what this is. This is invasive aspergillosis. The enhancement is really going to depend on immune status. So very immunocompromised patients, you may not see much enhancement. And essentially what you're seeing is septic infarct. So you have angioinvasion by the hyphae, which you can see here with the silver stain. And you can see this is a blood vessel here to the right with the red blood cells in the lumen. And these are the organisms invading the wall of the blood vessel. So you're going to see the dark T2 signal, and hemorrhage is a key. But really be thinking of this when you're dealing with neutropenic patients. So the history is going to help you a lot. Minimal mass effect. They can be direct extension from the sinuses or hematogenous extension from the lungs. So the third pattern that we're going to discuss are temporal lobe lesions. So here's a 26-year-old male with seizure and fever. And when you look on the flare, you see T2 hyperintensity or flare hyperintensity involving the medial temporal lobe, patchy and linear enhancement on the post-contrast, and reduced diffusion. And of course here your number 1, 2, and 3 is herpes encephalitis until proven otherwise. And you can even look back on this patient's non-contrast CT and see a very subtle abnormality there in the medial temporal lobe. So this is so important to suggest because it's the most common fatal encephalitis from reactivation of herpes simplex 1 that lies dormant in the trigeminal ganglion. It's going to affect the medial temporal lobe and limbic system. It's usually bilateral but asymmetric. The enhancement can be variable, so early on you may not see enhancement or you may see only patchy enhancement, and later you may see the more typical gyriform enhancement. The diffusion is usually positive. So this example just illustrates the geographic distribution of herpes simplex. You can see in this case it is bilateral. You can see the involvement of the medial temporal lobe. So here there is involvement of the lateral temporal lobe, but note, before you're going to get involvement of the lateral temporal lobe, you're going to see involvement of the medial temporal lobe. You also see the involvement of the insula and the cingulate gyrus. Notice here how it spares the basal ganglia. This is an important distinction from one of the mimickers, which is an MCA infarct. And here you can see the reduced diffusion. Okay, so what's the differential for temporal lobe lesions? So what do you think about this case? On the CT, we see a large area of abnormality in the left temporal and frontal lobe and extending into the basal ganglia. And here the clue really is the extent into the putamen, and this is an MCA infarct. In the coronal flare, you can see abnormality really in the lateral temporal lobe, sparing the medial temporal lobe. So that's a clue that you're not dealing with herpes, and this is another MCA infarct. When you look at this coronal flare, you can see the hippocampus here is expanded, so mass-like flare hyperintensity, and this is a low-grade glioma. These are usually not going to enhance and usually not going to have reduced diffusion. And then on the final image, you see multifocal abnormality involving both temporal lobes and the pons in this patient with gliomatosis. So we're going to move on to white matter lesions. So this coronal flare, you see fairly symmetric white matter abnormality in a 42-year-old with gait imbalance. And we're going to pause here and talk about the differential for bilateral white matter abnormalities, which you see every day on a CT scan. So small vessel ischemic disease, normally more patchy, periventricular and subcortical, but can be confluent. Treatment-related changes, transependymal flow of CSF with hydrocephalus, demyelinating, especially end-stage demyelinating disease, HIV, CMV, and PML. And here's where history is key. You find out the patient is HIV positive, and you can focus on all those entities that are seen in the HIV population. And here's the patient's axial T2 and post-contrast. You notice the diffuse volume loss, the confluent white matter T2 abnormality, the lack of enhancement, and these are the classic imaging features for HIV encephalopathy. The main differential here is PML. This is our last unknown case. This is a 34-year-old with HIV and right hand weakness. And on the CT, you see asymmetric white matter abnormality involving the subcortical white matter, extending out to involve the subcortical U fibers. And note on the T1 how dark it is on the T1. It's very hypo-intense on the T1, unlike HIV encephalopathy, which you usually cannot see on the T1 weighted images. And this is PML. And this is that patient 3 months later, and you can see how rapidly confluent it's become. This is a subacute demyelinating disease. Unlike HIV encephalopathy, which usually presents with a dementia, PML can present with more focal symptoms, so a slow stroke. And the location, the classic locations, parieto-occipital, remember the middle cerebellar peduncles are another classic spot to see this. Here's just another case of PML. Asymmetric white matter involvement, no mass effect, involving the subcortical U fibers. Here's a subtle case, an HIV male with headache and altered mental status. So I included the patient's MRI from 6 months prior to help bring out the abnormality. And you can see that around the ventricles, you see this pencil-like T2 abnormality outlining the frontal horns, the third ventricle, and the lateral ventricles here. And you see on the post-contrast, the subependymal enhancement lining the ventricles. And this is a patient with CMV. And this is a fairly classic appearance for CMV, that you see this pencil-like thin periventricular T2 and subependymal enhancement. And the last pattern we're going to discuss are lesions in the basal ganglia. So this next patient is a 40-year-old male with a headache. And you can see on the T2, we have abnormality in bilateral caudate heads, in the putamen bilaterally, and even in the thalami bilaterally. So we're going to pause here for a differential on basal ganglia lesions. So of course, infection, toxoplasmosis, Cryptococcus, and CJD. Toxic metabolic abnormalities, so extrapontine myelolysis, and also mitochondrial disorders and Wilson's disease. Ischemic, remember when you see bilateral abnormality in the thalami, one of the things to think about is internal cerebral vein thrombosis. And then neoplasms, lymphoma, and glioma. And we find out this patient is also HIV positive, so we're going to focus on those disease entities that are seen in the HIV population, keeping in mind that they are so susceptible to some of these more common abnormalities. So on the post-contrast, you can see that there's no enhancement. So this makes lymphoma or toxoplasmosis unlikely. And then you look on the diffusion, and you can see there's no reduced diffusion, making infarct less likely. And this is a case of Cryptococcus, and these are gelatinous pseudocysts. Cryptococcus is a yeast that's normally inhaled, but in immunocompromised patients can become hematogenously spread and cause a meningitis. You can get intraparenchymal cryptococcomas, but rarely. So what we're seeing here are the gelatinous pseudocysts, which are dilated Virchow-Robin spaces. They're non-enhancing, and they're in the basal ganglia and the thalami classically. Here's a spectrum of the imaging appearance. You can see a more focal lesion in the left putamen, and you can see in this axial T2 more diffuse abnormality involving the caudate heads bilaterally and the putamina. On this coronal growth section, you can see the Virchow-Robin spaces dilated with mucin, and here's the India ink stain showing the organisms. So the next case is a 40-year-old HIV-positive male with right hand weakness, and you see two distinct lesions. The first is this calcified lesion in the right caudate head with no edema. So here is a remote lesion. And then you see a more active lesion in the left thalamus, which is ring enhancing. So now you have a ring enhancing lesion in the basal ganglia in an HIV patient, and you should be thinking of two things, toxoplasmosis or lymphoma. And this is a case of toxoplasmosis. So the calcified lesion in the right caudate is a fairly classic example of treated toxoplasmosis, and then the ring-enhancing lesion is the active toxoplasmosis. So how do we distinguish toxoplasmosis from lymphoma? Well, there are really no rules here. There are some guidelines you can use. If they're multiple, you can favor toxoplasmosis. The eccentric target sign actually is a very good sign. It's not very sensitive, but is specific. Things that can favor lymphoma, subependymal enhancement or involvement of the corpus callosum, and more dark T2 signal, which suggests hypercellularity. But in the end, we usually treat these empirically, wait 7 to 10 days, and re-image. If there's improvement, then the diagnosis is toxo. If there's no improvement, the patient goes on to biopsy for lymphoma. So toxoplasmosis is the most common CNS mass in the AIDS patient, and it's spread through cat feces and the parasite Toxoplasmosis gondii. And here's an example of the eccentric target sign. And you can see here, very specific if you see it to suggest toxoplasmosis. So here's a 7-year-old with rapidly progressive dementia. And on the axial flare, You can see T2 hyperintensity in the caudate heads bilaterally and the putamina, and you can see diffuse abnormality in the cortex. And when you look on the diffusion, you can see reduced diffusion there in the caudate and putamen. And what we see is cortical ribboning. Sorry, the arrows are a little bit off. But you can see the cortical ribboning here and reduced diffusion in the cortex diffusely. And this is a patient with Creutzfeldt-Jakob disease, which is a prion disease resulting in a rapidly progressive dementia and death. So the last case here is a 15-year-old female with ataxia and dysmetria. And you see on the axial T2 weighted sequence, T2 hyperintensity and mass effect in the cerebellar hemispheres, also in the coronal flare, and this is cereballitis. Key that this is either infectious or para-infectious, but resolves spontaneously, so the treatment is really supportive. So in summary, we've talked about a really practical approach, so 5 basic patterns. When you see extraaxial pattern, epidural or subdural, look at your paranasal sinuses for a source. For ring-enhancing lesions, remember the light bulb bright reduced diffusion for pyogenic abscess, the dark T2 for TB, the Scolex for Neurocysticercosis, and look for calcification on the CT. For temporal lobe, remember that herpes involves the medial temporal lobe, spares the basal ganglia, unlike an MCA infarct. Basal ganglia lesions, remember our differential for toxo versus lymphoma. White matter lesions, we'll use these specific imaging characteristics in clinical history.